Our next organ is going to be the kidney, so we're going to move from the brain to the heart into the basement, and we're going to be talking about kidney failure. Our speaker will be Dr. Tobe, who's the inaugural Heart&Stroke Foundation and Northern Ontario School of Medicine Chair for Rural and Aboriginal Health 2013. He's a nephrologist and a hypertension specialist. He works at Sunnybrook Health Sciences Center. He has a master's and is an extensive teacher and a degree in teaching from the Dalai Lama School of Public Health. Yeah, okay. I won't belabor, but he is one of the, oh, there's the slide I was talking about. You follow these instructions to get to the texting and the audience response system. Lastly, I just want to mention that Dr. Tobe is one of the co-chairs and real drivers behind C-Change. If you're in family practice or internal medicine, the C-Change guidelines have been all the rage these last couple of years. Organ failure, focus on the kidney with Dr. Tobe.
Thanks, Ritesh. So just in comparison to Mike's talk, I want you to pull out your cell phones now. And we will do some cognitive testing by seeing if you can follow these instructions. So it's a pleasure to talk today about the kidneys. And, really, we're going to focus a lot on blood pressure, no surprise. And we will also talk about cholesterol lowering. And those two things turn out to be really great for people with kidney disease. So that's the end. You can just start texting now, and you've got the summary of the whole session. So let's start with this question. Which of the following is most correct? Chronic kidney disease and albuminuria increase the risk of progressing to dialysis more than the risk of developing cardiovascular disease. The CCS lipid guidelines recognize chronic kidney disease as a high cardiovascular risk category, or only very low-dose statin should be used in patients with chronic kidney disease because they are so frail and so susceptible. Okay, all right. So we can just skip right to the end, it looks like. It's pretty good. And I'm going to work through one of our education modules that I've modified for this session. And thanks to all those folks who helped to develop it. And some disclosures from some clinical trials that I'm involved with. None will conflict with this talk. So let's just go back. There we go. Here's Donald, who is a 55-year-old man, and he has a previous left nephrectomy and hypertension and comes to your office after moving into the neighborhood. So our objectives are to identify patients with chronic kidney disease, to formulate a treatment plan for managing the cardiovascular risk that is associated with this condition based on our updated guidelines, and to communicate this treatment plan to your patient to help to reduce his risk of progression. So Donald is 55. He had a kidney removed remotely for renal cell carcinoma. He's done very well. And he shows up in your office for review. Of interest, in his previous neighborhood, he had been involved in a study called SHARP, which was the study for heart and renal protection. And that was a study looking at patients who had chronic kidney disease and preventing cardiovascular disease with lipid lowering. So he knows that the study has been completed and wants to know, based on the results of that study, if he should be on therapy. His blood pressure has been well controlled, and he's been on an ACE inhibitor, calcium channel blocker, two medications, and he's a non-smoker, uses alcohol only socially, and he's separated with 2 adult children. His father, he has a family history of premature cardiovascular disease, with his father dying early from a stroke. His mother is hypertensive. So we can assume that both of his parents were hypertensive. And all his older brothers have hypertension. His current medications, calcium channel blocker, ACE inhibitor, and he's on aspirin. Physical exam, really quite unremarkable. His BMI, much better than my own. Blood pressure taken with the BP True in the office, unattended, 148 over 92, and the rest of the exam is normal. Here's his lab tests, and let's just focus on the middle row. Starting from the right side, 5 years ago, we can see his creatinine was 186, then 165, 170, 190, 151, 157. So his kidney function has been very, very stable over time. So, question 1. After completing your introduction and orientation to your office in your initial evaluation, you turn to his blood pressure. His blood pressure is 148 over 92. What is the target blood pressure for Donald? Please vote. Good, so we can have some learnings today. That's good. Okay, let's move on. So 140 over 90 was correct until this year. And now that we have a new recommendation based on the SPRINT study, Donald would actually be a SPRINT candidate because he has chronic kidney disease. So 140 over 90 is no longer correct for this patient. 130/80 was correct in the past, and we thought that lower blood pressure targets were good for patients with chronic kidney disease to protect their kidneys. But studies done, the African American study of kidney disease and the RAIN study, looked at lower blood pressure, intensified blood pressure control for renal preservation, but neither study demonstrated a renal benefit of the intensified lower blood pressure. Both studies were big from a kidney perspective, but they weren't big enough from a cardiovascular perspective. They weren't powered enough for cardiovascular protection. And the correct answer now is less than 120 because he would be a SPRINT candidate. And the SPRINT study included a renal subgroup. It was subscribed for patients with chronic kidney disease to look at the effect of intensified blood pressure lowering in these patients on cardiovascular outcomes. And in the SPRINT study, despite the SPRINT study was stopped early because there was a dramatic reduction of cardiovascular events, but there was no improvement in renal outcomes consistent with those previous studies. Now, SPRINT was designed to last 6 years, and here are the kind of patients that would get into SPRINT, age 50 and above, systolic blood pressure 130 and above, and they had to have some other risk. So Framingham risk score at 15, you could get a Framingham risk score at 15 just by being old, so age 75 and above, and patients with chronic kidney disease. These were the most common patients that were in the SPRINT study. SPRINT was designed to last for 6 years, looking at the question, does intensified lowering of blood pressure help to protect the heart and the brain? And the SPRINT Mind was really the brainchild of this whole study, designed to look at whether intensified lowering of blood pressure can prevent dementia. The study was stopped early at 3.2 years and reported in November 9, 1 year ago, because there's a dramatic reduction of cardiovascular death. And the composite outcome also was significantly reduced, largely driven by heart failure. So blood pressure lowering can help us keep patients away from those LVADs and hopefully keep our patients out of heart failure as well. We're going to find out the dementia results apparently in June, but I'm not sure how much, excuse me, how much we're going to find out given that the study was stopped so early. That's led to new recommendations that came out in 2016 from CHEP and the Hypertension Canada, where we have a new row for blood pressure control. For a high-risk patient that would be in SPRINT, we have thresholds for treatment of 130 and a target for lowering blood pressure to less than 120. Patients with diabetes remain less than 130 over 80, and everybody else 140 over 90. So why did SPRINT show a nice reduction of cardiovascular events, a benefit, in patients with chronic kidney disease, and yet the previous studies hadn't shown any benefit at all? what is it that might have been competing with improved renal function? And you mentioned competing risk, Mike. So yes, there for sure is competing risk, and our patients with chronic kidney disease have this competing risk from heart disease and stroke and sudden death. So you have to have a really big study to look at the cardiovascular outcomes. Okay, so we know what the blood pressure target is for this patient. Now, what about the rest of global cardiovascular risk management? He's mentioned the SHARP study. So you pull out your smartphone and you quickly look it up and get the PDF, and you read up and wow, it's pretty exciting. So what are you going to tell him about lipid lowering? That he's only at intermediate risk and need not worry. That because of his kidney disease, he is at higher cardiovascular risk and needs to lower his LDL to less than 2, or at least have it cut in half. Or that he is at high risk, but his LDL only needs to come down to less than 3, or a 25% reduction. So please vote now. So what's the evidence around this? In the SHARP study, based on the SHARP study, the CCS lipid guidelines say we recommend a statin or a statin ezetimibe, ezetrol, combination in adults 50 years of age or older with chronic kidney disease, as long as they're not treated with dialysis or a kidney transplant. And in patients, and so those are patients whose GFRs are low, 20 to 60, and if they have chronic kidney disease, a GFR above 60 mils per minute, but they have abnormal albuminuria, they would also qualify for that recommendation. So who has abnormal kidney function and who has abnormal albuminuria? And here's some data that comes from the NHANES, the National Health Awareness Nutrition Evaluative Survey in the US, and this is the latest wave. The incidence of low GFR in these patients, we can see in the top row, in the middle row, eGFR less than 60, overall is 7%. And looking at the columns, the middle column, abnormal albuminuria, also 7% in patients whose GFR is normal. So I've tried to show that with the overlapping Venn diagrams. And of interest, 7% of people with normal GFR have abnormal proteinuria. They're not all people with diabetes. And a surprising number of people with low GFR do not have albuminuria. So there's something interesting going on, and we don't know what it is that's causing the albuminuria and the low GFR without albuminuria. In my mind, the albuminuria may be linked to endothelial dysfunction, and the low GFR without albuminuria might be a purely ischemic lesion. And it's interesting to correlate that to what's going on in the brain as well, because I think there's a lot of correlation between chronic kidney disease and cognitive decline. The total number, when you add those two together, is around 14% of the population who has either a low GFR or a normal GFR and abnormal albuminuria. So what's Don's GFR? You could do the old Cockcroft-Gault equation or plug it into one of the newer formulas, the CKD Epi, where you don't have to know his weight. And it pops up a number of an eGFR of 50. So yes, he is a sprint candidate. And he is, based on the CCS lipid guidelines, at high risk. So the patient does meet the criteria for intensified lipid lowering. So we've got to get his LDL down below 2, or if it was much higher, to get a 50% reduction. And here's some of the data showing that patients who have chronic kidney disease are at higher cardiovascular risk. This study comes from Alan Go, and it comes from the Kaiser Permanente population base in California. And it's a very OHIP-like group, and they collect amazing data, and they do some terrific analyses. And it's also the only jurisdiction in the world that's equal to Canada for blood pressure control. On the x-axis of all these graphs is eGFR, going from, on your left, greater than 60 to the far right, of each graph, less than 15. And you can see higher risks of bad events, death, cardiovascular events, and hospitalization for lower eGFR with each one of these. So this is a big observational data set right across the Kaiser data. And this is just over 1 million adults. This next graphic showing you the same idea comes from the OnTarget study, and it's something I was fortunate enough to get to work with, again, with the PHRI and Salim Yousaf's group in Hamilton. So 24,000 OnTarget patients. These are patients age 55 and above, very similar to HOPE patients with higher cardiovascular risk. And if you look at the bars in the black and white, those are bars for sudden death. The y-axis is the outcome for death or ending up on chronic dialysis. The colored bars on the right are ending up on dialysis. So the first thing you can see in the OnTarget population is that dying is much more common in these patients than ending up on dialysis. Again, this idea of competing risk. So if we're looking at renal outcomes, it's really hard if all the patients are having cardiovascular events or dropping dead. If we look at the other axis, we can see normal microalbuminuria and macroalbuminuria. So the more albumin in the urine, the greater the risk of ending up on dialysis and the greater the chances of dying during the study. And we can see that the highest chance of dying in the study is in patients, and the two rows in each one, there's the low GFR and a normal GFR, both for cardiovascular events and for ending up on dialysis. So the highest bar, the worst outcomes are those patients who have a low GFR and more albumin in the urine. But we can see here that, again, the risk of dying is much greater than the risk of ending up on dialysis, and that's not counting all the heart attacks and strokes that people survived. One last data set, a very new data set that is just coming out in publication now from Finlay McAllister and a group in Alberta, looking at institutional databases, patients with atrial fibrillation, followed from 2002 to 2013. And these are patients with non-valvular AFib. And again, the x-axis is different eGFRs starting on your left from greater than 60, and the purple bar less than a GFR of 30, and the y-axis is hazard ratio for the chances of any of these bad events. So all-cause mortality, 8-fold more likely in patients who have a low eGFR compared to those whose GFR is normal. Stroke, 3 times more likely, and bleeding events for those patients with atrial fibrillation similarly higher. So lots of evidence that patients with chronic kidney disease have a much greater risk of bad cardiovascular, cerebrovascular events than they do ending up on dialysis. So here's a nephrologist telling you, don't worry so much about the kidneys, focus on the heart and the brain. So patients with chronic kidney disease are at higher risk of cardiovascular events. The risk of cardiovascular events is much higher than the risk of renal events. Now, of course, the treatment that we're going to give them to manage their cardiovascular risk is exactly the same and more than what we would do to treat their renal risk. So he asks about lipid-lowering therapy, and yes, we should lower his LDL aggressively below 2, or at least cut it in half. We should do that with statins and what other agents are necessary. So what therapy should he be started on for his lipid management? A, sufficient therapy to achieve targets, or B, only low-dose statin or fibric acid derivatives. I think I've given this away already. Please vote. Very good. Okay. Message received. Very good. Sufficient therapy to achieve targets. So the SHARP study was the largest renal study completed. 9,400 patients. Mike, can I trouble you for a little water? And 6,000 of those initially with chronic kidney disease and 3,000 on dialysis to start. And they all got simvastatin 20 and isotrol 10 milligrams. And in the UK, that was available as a combination pill. The main outcome was cardiovascular. There were renal outcomes looked at as well. And here's the main cardiovascular outcome. Nice separation of the curves after a year. And the main reduction of cardiovascular events came in prevention of the need for revascularization. And here's just a forest plot of some of the vascular protection, and major vascular events nicely protected by lipid lowering in patients with chronic kidney disease. And this was primarily the case for patients not yet on dialysis. So if they end up on dialysis, we would continue their statin therapy on dialysis. Remarkably well tolerated. So the event rate of myopathy and various other things in the treatment and the control group were very, very similar. The result was a recommendation from the CCS lipid group to recommend a statin or statin ezetimibe combination to reduce cardiovascular events in adult patients age 50 and above who have chronic kidney disease or a kidney transplant. And so the correct answer is, as you pointed out, sufficient therapy to achieve our targets. So Donald is pleased to know the results of the SHARP study and the resulting new lipid guidelines. He willingly starts on therapy, and he started on atorvastatin and ezetimibe, and his LDL nicely comes down to below 2. He tolerates the therapy, he does well, no aches or pains, and he lives to a ripe old age. So our key message from this section on the kidney is that kidney disease is prevalent. And kidney disease is both low GFR, and about 7% of the population has a low GFR less than 60, and an abnormal albuminuria. And the main causes of kidney disease, diabetes and hypertension, contribute to both. Albuminuria and low eGFR are both markers of both renal disease and global cardiovascular risk. Global cardiovascular risk should be managed aggressively, blood pressure lowering, use of RAS blockers, lipid lowering, keep the blood sugar under good control, smoking cessation, of course, proper diet, and exercise. Those things are good for the heart and the brain. They're also good for the kidneys. So I was hoping that we could identify a patient with chronic kidney disease, both with the low eGFR and abnormal albuminuria, formulate a treatment plan for addressing global cardiovascular risk in these patients. And if we focus on the global cardiovascular risk and global cardiovascular risk reduction, we're also going to get renal protection in these patients. And we need to be able to communicate that to our patients and help them start on therapy and do well. So we can go back to the original question again, and I don't think we really have to compare the two, which I was planning to do. So just as a reinforcer, we might as well go ahead. Please vote for which of the following is the most correct. And this is the same as the first question. Okay, message received. Well done. Thank you very much.